Okay. Yeah, first of all, like, awesome to be here. Thank you so much for this opportunity to talk a little bit about the work we've been doing for the past 8 years or so. Um, Feel free to interrupt at any time. Honestly, that just doesn't have a formal flow. It's a kind of hopefully it's a learning experience. I kind of got the impression that this is sort of an opportunity to talk to you a little bit about biomarkers and how we build them and how we use them clinically. Um, so disclosure is obviously employed. So the agenda here, and I think this is sent out, really is to understand first how biomarkers can inform current unmet needs in bladder cancer. And I'm going to talk a little bit about how we actually do this. Like, how do we build a model? How do we leverage gene expression profiles and build a molecular assay? And finally, since there is a lot of controversy around subtyping in bladder cancer, based on nomenclature, the clinical results of using these assays, and a lot of controversy, I think I'm going to talk to a little bit about how we can intersect and sort of address this issue. And I'll show you how a lot of it's just naming. We're actually talking about the same thing. We're just looking at it a little bit different lenses. So first, biomarkers and clinical unmet need. There's a lot of challenges, I think, in bladder cancer management. And so the way we're looking at this is, you can take your TURBT sample and you can do your MRI or your CT scans, and you basically get an idea of the clinical stage and some estimate of the risk of progression or how aggressive the disease is. Concurrently, you can actually do a lot with that tumor tissue, including extract gene expression profiles through RNA, DNA mutation sequences through DNA. You can do IHC on the actual tissue sample. You can do imaging. And using this information, you can either use this independently, so you could look at a single gene as a marker, but you can also build a classifier, a model. And we call these model objects when we do our actual data science components of this. And so for muscle invasive bladder cancer, which I think we're going to focus on today, I want to do a little bit of non-muscle, but we're not so far ahead in the company yet with that. But for muscle invasive bladder cancer, some questions around, neoadjuvant chemotherapy. We generally use this routinely, but do we always want to? There's a lot of other neoadjuvant therapies coming out, including immune checkpoints, and even simply something as clear as prognosis, like how bad is this disease and how well is my patient going to do? Non-muscle, I think the questions are similar, but looked at slightly different. Is the patient going to respond to BCG? Do they need surgery? Is this an aggressive tumor? Do I need to get this out of the patient quicker? How aggressive is the disease? And finally, and this kind of ties into muscle invasive bladder cancer a little bit, but there's a lot of challenges with clinical staging. So I'm going to talk a little bit about that as well. And so in addition, the typical clinical tools, imaging, TURBT, one of the questions we look at is really, can we use tumor biology to help inform the management of patients with bladder cancer? And so when I talk about biomarkers, really the focus for today's discussion is going to be around molecular subtyping as a biomarker type. Although, keep in mind, it doesn't have to be limited to molecular subtyping. You can basically build a biomarker model against any clinical endpoint, and it can be a binary classifier, it can be an A/B, or it can be a continuous classifier, so a risk of progression score, for example. Subtyping is one of these categorical biomarkers, so we'll talk a little bit about that. This is an area I spent a lot of time in, so hopefully I can answer any questions you have regarding this. So I guess at the highest level, for those of you who may not be familiar, what is molecular subtyping? So basically, this is just a way to bucket patients into a group. So this uses gene expression data primarily. Since bladder cancer tumors are so heterogeneous, this actually can give us a lot of information. And we find using molecular subtypes that you can actually have very consistent biological and clinical features associated with any given group or subtype. So where does this come from? So really, this has a lot to do with the biology of the urothelium, which may or may not be surprising. You can see here, this is a cartoon of the urothelial layer. You can have the basal layers at the bottom. So these are highly undifferentiated cells that can differentiate upwards towards the more differentiated or umbrella cells. And so what makes this interesting or important is that the biology of subtypes is generally associated with the biology of the urothelium. Oh, right. Does this help? Thank you. So you can see that the basal cells down here differentiate up into umbrella cells. And what's important here is that basal tumors tend to have a biology very consistent with basal cells, and luminal tumors tend to have biology very consistent with umbrella cells. And this isn't to say that the luminal tumors arise from umbrella cells or basal tumors arise from basal cells. We don't know this for sure. But it's more like the tumor sort of adopts the biology as it would if it was trying to be a urothelial cell type. So there's a number of different classifiers, and I'll talk about three major ones. Part of the reason, of course, I'm not supposed to be too commercial, but one of the reasons we wanted to talk a little bit about this one is it because it is a commercially available classifier, and there's a lot of interesting data and story associated with what this assay actually does and how we use it clinically. But most of what I will talk about is very academic, I promise. So the Decipher Bladder classifier actually recognizes 5 different molecular subtypes. Has a luminal group, an infiltrated luminal group, a basal group, and a basal claudin low group. And so each of these has a unique biology. The luminal tumors tend to be very differentiated, express a lot of luminal type markers like GATA3, PPR gamma. The infiltrated luminal tumors tend to express some luminal markers, but also have high levels of stromal infiltration. We're actually working on a manuscript to describe this. The basal tumors have higher expression of basal markers such as KRT14, KRT5, tend to be less differentiated. And the basal claudin lows are very much like basal tumors, but have like a very, very high level of immune infiltration. And that becomes important later. And finally, I don't want to belabor neuroendocrine-like because I'm going to talk a lot about this, but this is a group of tumors that has conventional urothelial carcinoma presentation histologically, but genomic features very consistent with small cell or neuroendocrine-like disease. And so how we use this as an actual clinical test at present is we look at a couple of different features. So the luminal tumors generally tend to have a lower risk of upstaging, so they're more likely to be organ confined. And they tend to have less benefit from neoadjuvant chemotherapy. And I'll talk to you a little bit about the data that got us to that point. Another personal favorite, I guess, something I definitely worked on quite a bit with Gordon Robinson and Seth Lerner, TCGA. So this classifier recognizes 5 different molecular subtypes. Luminal papillary, so again, this has your FGFR3 expression, more differentiated. A luminal infiltrated group, which has, again, the more immune and stromal infiltration. And this is an important feature too, because you'll notice these names come up again and again in different classifiers. And this is actually part of the source of the problem when we're looking at different classifications, getting different results. Just because their luminal infiltrated is called luminal infiltrated doesn't make it the same as the GSC or Decipher Bladder luminal infiltrated population. We have another luminal group, slightly different than the others. To be completely honest with you, I'm not entirely sure why we came up with this one. Hindsight is 2020, might not have put it in, but that's what we were working with at the time. Your classic basal squamous group, and then the neuronal group, which again is quite important for how these subtyping models develop, and I'll talk a lot about that downstream. And then later on, about 2019, I say area, the community got together to sort of address all these subtyping models, because I think at that time there's probably about 8. So they wanted to create a consensus model which we could use, first as a reference point, but also as a clinical tool. Unfortunately, to date, I would say that there's no data suggesting we should use this clinically, but as a reference tool, I think it is quite helpful. They recognize, another, again, 3 groups, various luminal groups. So there's a luminal basal axis as before, but they also recognize a stroma-rich population. And this is possibly because they include a lot of radical cystectomy tissues in their classifier development. And from some of our data, which I'm not going to show you today, we do find there's like a scar-like or stroma-rich population after systemic therapy, or even without systemic therapy at radical cystectomy. So this may have come from that phenomena. Okay, so far so good. So how do we use this?
Can I ask you a question?
Yeah, of course.
You'd be able to tell that stroma-rich was mostly suspected.
You would if you had. Yeah, we could definitely do that. Yeah. They didn't, you know what? I think it was something that people didn't really recognize until later. It's some of the work we've been doing, with yourself and with Andrea, that we're starting to see this phenomenon. And finally, we see it in the abacus cohort as well. So there's, it's kind of a consistent phenomenon where we see these tumors that have a profile that's very consistent with scar tissue. In fact, it's so similar that you almost couldn't distinguish it. So there's something going on there. We're not quite sure what's going on, if it's a tumor scarring itself or if it's healthy scar tissue infiltrating the tumor bed, but it's definitely consistent across multiple systemic therapies. Okay, so first question is really, can we use biomarkers or subtyping to help stage patients better? So particularly in risk of upstaging cystectomy. And I said, I really don't need to belabor this to this group, but upstaging remains a major clinical issue. So a lot of the time, 40 to 50% of the time, you're staging someone at clinical T1, T2, but in fact, they actually have non-organ confined disease. And here we're defining it as PT3 plus and or nodal involvement. And so we find this at radical cystectomy with staging. So why does this even matter? Well, of course, as we know, and this data is based on a cohort of 206 patients treated with radical cystectomy only, so no systemic therapy, all clinical T1 and T2. And you can see when they're upstaged, when they're non-organ confined, people generally are not having a very good day. When they are organ confined, surgery can be curative, and so they're doing much, much better. And so part of the reason this matters is because if we were to see them upstaged non-organ confined disease, and we could determine this at T or BT, so right at diagnosis, then you could intervene with neoadjuvant chemotherapy. And so instead of taking them right to surgery, you could give them like an opportunity to get treated a little bit more aggressively. So what we did here is we actually asked, of course, yeah.
Could you please clarify what upstaging means for me? I'm not too sure. Does it mean just staging the cancer?
Do I need to press the button too?
No.
Okay. Just making sure. It basically means, like if you go back to here, so if a patient was clinically a T1 or T2 patient with like no nodal involvement, if you go ahead and you do the surgery, you take out the bladder, when you do the pathological staging, and if the tumor is then anything higher than a T1 or T2, it becomes a T3 or there's nodal involvement, then they consider that upstage. So it starts at a lower stage and then comes up to a higher stage. And so we're trying to use basically genomics to say, can we better predict which tumors have a higher probability of upstaging? So which one's more aggressive, I guess is another way to put it. So we asked the question, really, can we use molecular subtyping to predict upstaging? Is there a difference between, say, luminal tumors, which we understand are less aggressive, to non-luminal tumors that are more aggressive? And the answer to that was yes. In fact, there was a difference, and it was a significant difference. So you can see that the rates of upstaging for luminal tumors, and again, this is to non-organ confined disease, defined as PT3 plus and or nodal involvement, was 34% compared to 51% for non-luminal tumors. So this is actually quite a big difference. So you could say that luminal tumors are more likely to be cured with cystectomy only and might actually be able to avoid chemotherapy simply because they are organ confined. And does this translate into better outcomes? And again, yes, the answer is it does. So you can see our luminal patients in this population tend to do a little bit better, significantly better, but I wouldn't say this is dramatically different. So we're sort of moving towards the direction where we can say, okay, yes, there's signal in these data. There's a population of patients that are more likely or less likely to be upstaged and going to do a bit better than their counterparts.
Can I ask a question?
Of course.
Just a quick question. So I think the luminal or non-luminal tumor category, so recognized at the timing of T or BT, but at the time of cystectomy, is there any change from luminal to non-luminal, or any crossover?
Generally, well, this is a good question. Generally, without systemic therapy, they're fairly consistent.
Okay.
However, I say that kind of with a however and a but. There is some evidence that this scar-like group I was talking about can show up without systemic therapy too. So there's potentially an impact of TOR. But generally, for the most part in our data, what we've seen, they are quite consistent.
Very consistent. And then there's no mixed tumor.
Right.
Okay, right. Thank you.
What you're identifying here is a prognostic signal.
Mm-hmm.
And, parallel in prostate cancer is if your P53 altered, you have a more aggressive phenotype that
Mhm.
should undergo treatment intensification with additional systemic therapy on top of, say,
Mhm.
androgen pathway inhibition, AR pathway inhibition. And if you add chemo to that group, it doesn't make a difference because
Right.
it's intrinsically aggressive.
Right,
It
right,
doesn't predict for chemo
right.
sensitization.
Right.
So I think you have to be careful about saying that this is a group that should get chemo
Mhm.
unless you actually have demonstration that you're
Absolutely.
changing those curves.
Absolutely.
So do you have data to suggest that you're
Not-
changing those curves?
Not yet. No, I think this it's sort of a stepwise process right now. It's first, is there a difference in sort of the outcomes of these patients just as is with standard of care? And the next step, I think, is can we subset the patients in this curve here and identify the patients really who should be getting chemotherapy? And we're not quite there yet. That's some work to be done.
Or treatment intensification.
Intensification, yeah.
Tempting.
You have before this, you had evidence that non-luminal tumors, if you take a cohort not treated with chemo,
If you
otherwise it will die.
if you have a cohort treated without chemo, so just cystectomy, and then a separate cohort treated with cystectomy, that the non-luminals benefit more from neoadjuvant therapy. So there is some predictive nature to it as well, right? So this builds on that.
Yeah.
Not only do your luminals just do better, and maybe not need chemo, but there's evidence that the others actually benefit from chemo.
Right.
So there is some predictive to it.
We're gonna get there in a couple slides. So we did a little bit of a follow-up study here. So this is actually unpublished data. In this study, we're looking at non-muscle tumors, so TAs, TIS, and T1s upstaged to muscle invasive, so anything T2 or nodal involvement. Here again, you see very, very similar patterns. We see about 30% of luminal tumors are upstaged versus about 50% of non-luminal tumors. I think this is maybe more of a clinically important finding, in that like you might do something differently with a non-muscle patient who you think is muscle invasive versus someone who's simply upstaged non-organ confined disease, because you're probably not going to do anything different from a T2 to a T3. So I think this is maybe more exciting and more interesting data. What is, I think, the other surprising feature of this study is we found that there's really not a difference in the clinical T2 luminals and non-luminals with respect to upstaging. They're quite consistent, which was not something we expected to see. Okay. So how do we predict NAC benefit? So this is one of the original ideas behind the Decipher assay. And I borrowed this slide from Peter because I really like it. Kind of gives you some sense of like why neoadjuvant therapy kind of needs biomarkers to help decide whether or not we should use it. I won't belabor all of these points. I think what I like the most about this one is like Peter's suggesting here, and correct me if I'm wrong, Dr. Black, but there is a subset of patients who might not actually need chemotherapy, but we're giving it to them anyway, particularly in the US. So I'll show you a little bit of data around why we think that we can avoid chemotherapy for some luminal patients. And so the background from this is, luminal patients really have a less aggressive disease presentation. We've seen this again and again. This is a large cystectomy cohort. You can see that the patients here with the luminal line in blue, they're doing quite well compared to the other molecular subtypes. So there's a very big difference. So we're affected by good outcomes. I just showed you some data that luminal tumors are more likely to be organ confined at surgery. And there is some evidence in literature that not organ confined tumors have greater benefit from chemotherapy. So there's a number of rational points that coming together to suggest that we could avoid chemotherapy for luminals. And so ideally,
pause for 1 second on that. Go back one.
Sure.
Does that mean that it's independent of stage, or it's just more likely to be associated with lower stage luminal tumors?
Very tied together. Luminal tumors tend to be clinical T2 or lower. It's frustrating when we're doing MVAs for the upstaging project, because stage is such a driver of whether it was upstaged or not. Of course, the cohort we had was from tertiary care centers, which are probably very, very good at staging, versus the community doctors, which we'd probably be offering the test to.
I say none of us are good at staging, right? That's the whole problem. Is it's if the
data says something different.
if the TOR says muscle invasive, default is it's T2, unless you see something else on imaging or other suspicion. So a a lot of T2 is not T2. So, I mean, it's just a really bad classification.
Mm-hmm. And the data, I'll show you the data at some point. It's quite, okay. So ideally we do a clinical trial, right? We would take our luminal patients and we give them chemotherapy or not. Of course, we can't do that. That would be going against standard of care. So it's nearly impossible to do, at least in the US. Possibly could do this in Europe. So we did the next best thing. We assembled this cohort we call NAC meta. It's basically a meta cohort of a number of different cohorts we had in-house. Ended up with 828 patients once we filtered out for a number of various criteria, including filtering out neuroendocrine-like. And we do this because these patients tend to die within a year, so they would definitely influence the results. We end up with 601 patients. 247 patients had neoadjuvant chemotherapy, 354 did not. We used inverse probability weighting, which basically to balance out the clinical parameters these as best we could. We didn't account for subtype when we're doing this balancing. And so the subsequent KM plots you're going to see are going to have percentages and not actual individual numbers. And this is because some patients are upweighted or downweighted. So it'll be like 1.5 patient. So you can't really give a number. So that's why we do that. So sanity check for this cohort, we look basically at treatment versus not treatment. You can see that there's a net difference of about 7% at 3 years in this cohort, which is pretty much in line with the clinical trial data for the reporting about a 5% benefit. So knowing that this passed our sanity check, we started to move on. And we looked at luminal patients first. So this is just a luminal population. Again, with the inverse probability weighted data set, we see a negative net difference actually of 2%. So basically the curves are collapsed onto themselves, as you can see here, at 2% 3 years. Of course, we do not have a significant p-value. When we look at the other group, which is the non-luminal patients, so this includes infiltrated luminal, claudin low, and basal, neuroendocrine are excluded again. We see a net difference of 10% in overall survival at 3 years with a significant p-value that held up on MVA and UVA. So this is a pretty big difference because now we have a population of patients who aren't benefiting from chemo and a group of patients who are seeing, well, I wouldn't say benefit. Difference is the key word here. We're seeing a difference in these two groups. To support this even further, so this comes from the MOL2 data set, which I showed you with the non-muscle to muscle invasive upstaging population. In the clinical T2s, treated with cystectomy only, so this is no systemic therapy again. At 3 years, we see a net difference of 20% in overall survival for luminals versus non-luminals. So this is actually a striking difference, I think, and again supports the idea that non-luminal tumors could avoid chemotherapy. And so how does this all tie together? So really, we're starting to see the clinics and the biology aligning in the sense that, you know, for the tumors that are more likely to be non-organ confined and have higher rates of upstaging and benefit more from neoadjuvant chemotherapy, they tend to be non-luminal. So compared to the luminal tumors, which, you know, tend to be more organ confined, so lower rate of upstaging, and generally we're not seeing a lot of benefit from neoadjuvant chemotherapy. Again, this is all retrospective data. We don't have prospective data to support this, but I think it's definitely leaning in that direction. So that leaves the luminal patients kind of taken care of, but there's other groups. So another question is like, how do we predict benefit from immune checkpoints? And so we picked pembrolizumab largely because the data was available. But this kind of highlights how biomarkers kind of may or may not have utility. And so here, this is a cohort of 100, I think it's 108 patients treated with neoadjuvant pembrolizumab. They're all cisplatin eligible. 84, pardon me. So this is a classic biomarker, right? TMB and PD-L1 IHC staining. So this is what we always use in all these trials. And you know, whether or not they work that well depends. Here you can see for pathological downstaging that we have a significant difference for both TMB and PD-L1 staining. However, you know, whether this translates into something useful is kind of interesting because is this important for you when you're taking the bladder away? Yes and no. When you look at recurrence-free
on Friday,
Uh-huh.
buying us there.
Oh.
just this conversation. So when we look at recurrence-free survival rates for both TVM split on the same median that we see here, we don't actually see any difference. So whether the patient downstaged or not didn't actually result in a change in the patient's outcome. And I was thinking, as a patient, I'd rather have something that predicted a good outcome, even if I still had residual tumor in my bladder, as long as I'm doing well.
Yeah, I don't think everyone knows. Yeah.
Oh, I'm sorry. Tumor mutation burden. So this is basically just the amount of mutations there is in the actual genome of the tumor for the patient. Yeah, a predictor of immune response. It's as a biomarker. I don't know if it has that much utility. It's not as powerful as it should be, but it's what we have. Yeah.
Biomarker for
We can do better. We can do better. We can do better. So again, I'm going to belabor subtyping a little bit here, just because I think it's quite interesting how this works out. But so we'd use molecular subtyping on the same cohort. And what we see here is a consensus classifier and the TCGA classifier tend to have a nod of results. It's not really that informative. It's difficult to tell who's doing well and who's not doing well. You might say the basal patients in both these groups are doing a little bit better. But when you look at Decipher Bladder, the Decipher classifier, they're Claudin low patients. So these are the patients that have very, very high levels of immune infiltration, actually have almost exquisite outcomes. We have about 14 patients, only a single event in 3 years. So this is one of the first evidence, I think, that we have that, like subtyping classifier can be used to predict benefit to immune checkpoint. And this is why I think it might be a bit better than TMB or PD-L1 staining. And I think one of the important considerations too here is that we have to remember these immune checkpoint drugs are one, extremely expensive, and there's a lot of toxicity associated with them as well. So this is consideration. If we can give drug to a patient, it's going to work. It's going to work for them. That can save a lot of money in the long term, and also save a lot of patients a lot of discomfort. And so it's finally starting to show up in clinical trials. I think this is an exciting step forward, even though I'm not super involved in all of this work. But the Gusto trial, this is a UK-based trial led by Jim Catto. It actually uses our Decipher assay as a platform, but they're using the TCGA model to classify patients. So the design of this trial is basically the randomized to standard of care or to subtype stratified therapy. And what's important here is this particular group, the luminal papillary luminal tumors, are going to go right to radical cystectomy. And so this group, and I'll show you some data downstream, is very consistent with our luminal tumors, which I've shown you then have good outcomes without chemotherapy. And I'll show you how this aligns in the end. There's also this subtype trial led by Seth Lerner. This isn't launched yet. Gusto is running currently, but this subtype is not. This is still in the works. Very similar study design. And then there's Lumbernack, which is a trial we're proposing. Viggs and Som at Rutgers are putting this one together, where they're going to basically stratify luminal tumors to chemotherapy or to surgery directly using the Decipher Bladder assay. Okay, so take-home messages. Really, the challenges in the clinic here are the following. Biomarkers can, I think, address questions regarding prognosis, treatment response, and staging. Molecular subtypes are based on biology, which in turn, I hope I've shown you have a distinct clinical presentation in response to therapy. These luminal tumors, really, I'm showing you have lower rates of upstaging and minimal benefit from neoadjuvant chemo. And the question is, can we actually treat them with cystectomy alone? Is this going to be a valid approach? Claudin low tumors are highly immune infiltrated with very impressive response to pembro, but again, we need validation to confirm this is actually what's happening and not just based on the cohort. And there's a number of clinical trials that are ongoing using subtyping. So this is starting to emerge in the actual clinical setting, which I think is quite exciting. Okay. So next I want to talk a little bit about how we do these models, how we build these models, because I think this is a little bit of a black box for a lot of people. You hear, okay, we used a classifier and it did something cool, and that's all well and good. So I want to walk you through this process. Pardon me?
I said, I hope you use.
Oh yeah, and obviously machine learning, artificial intelligence. That's amazing. But we do use AI actually. It's kind of interesting. But AI is not as smart as people think it is. It does need to have its handheld, which I shall talk a little bit about. Don't be too overwhelmed by this. This is just a schematic. I'll walk through this for sure. But it's basically a number of stages to developing a clinical model. So the first is you have to have a clinical problem. So there's an issue, like I want to make an upstaging classifier. I want to predict recurrence-free survival at 3 years, like some sort of endpoint of interest, right? Then you need data. So you need, in this case, transcriptome data. I'm going to be a bit biased, but you can use, mutation status. You could use like imaging, H&E slides, which a lot of people are doing, like a Terra, for example, in prostate. Once you have all your data, and you need a lot of it, generally, it depends on what you're trying to build, but you do feature selection. So this basically is saying what features do I want to use to develop my model? So it could be genes of interest, but you need to subset. You can't have 40,000 genes and build a model. It just doesn't work like that. You need to pick genes that are going to be relevant to the endpoint of interest. You go through this training phase. So this is where you can kind of play. You build a number of different iterations of the model, and you kind of tweak them and try to get it closer and closer to what you want it to do. Once you think you have something reasonable, then you do this phase called testing. So this usually is done in a separate cohort, a separate group of patients or tumor tissues. And you go through an iterative sort of training testing process. You kind of tweak the model to get where you want it to be. Once you're confident you have something you think works, you have to lock it. You can't just play around with it. Once it's locked, you can't change anything. And then it goes through, and I think this is probably the most important step, is a validation phase. And so validation is key because your model may look great even once it's locked, but without further validation, you don't really know if it's performing as expected. And finally, and I think this is probably the hardest part, is you have to have clinical utility. So it has to be able to be deployed into the clinic, and it has to actually influence someone's decision, right? You have to have a physician using your test or using this model to inform what they're doing or to change their mind from what they're doing. And that can be actually surprisingly challenging. So I picked the neuroendocrine-like subtype as a sort of a model for how we build these. So I'll go a little bit into the background of why this came to be. So small cell bladder cancer, we usually use neuroendocrine interchangeably with small cell, but these do encompass small and large cell histology. There's a couple other variants, of course, as well. This isn't a huge problem. It only occurs about 1% at a time, but it's quite aggressive with high mortality and treatment resistance. And histologically, it looks very different from urothelial carcinoma. So you're not going to mistake it as a pathologist. So we're trying to help pathologists in a way here as well. So during the TCGA days, we actually noticed that when we're building our groups or our subtypes, that there was this one group of patients here who weren't not a small cell. There's a couple in here actually, but for the most part weren't small cell. They're urothelial tumors, but they had this gene expression pattern very consistent with neuronal tumors. And these patients tend to have very, very poor clinical outcomes. And so when I joined the Cypher team, or the Genome DX team at the time, we only had our 4 subtypes. We had basal, luminal, claudin low, and infiltrated luminal. We didn't have a neuronal classification. So we wanted to fix that and get that onto our test report too, because it was a population of patients who were doing very badly and probably needed treatment and intensification. So how did we go about doing this? So we first took a prospective training cohort. This is from the commercial use of Decipher Bladder. We excluded any tumors that had small cell features. So if anybody submitted a patient with secondary small cell variants present, we excluded them. And we started to pick our genes. And so the initial list of the features for our model training came largely from TCGA. So we kind of borrowed from what they were building out. We used gene set enrichment, and this basically is a way to filter high variance genes out of a data set. So we're looking for genes that are highly expressed or very poorly expressed in a small subset of patients. And it doesn't have to be any particular group of patients. It just has to be a small set. We curated literature looking for markers associated with small cell disease or neuroendocrine disease. And then we got clever and we used expert opinion, which is basically, people with a lot of background in this area would look at the gene list and say, okay, we want these markers in there as well. After filtering, we ended up with 84 genes, which we were using to define muscle invasive bladder cancer, neuroendocrine muscle invasive bladder cancer. And so this is where things get interesting. the number of genes we picked were actually not all neuronal genes, as you might expect. And there's a reason why we did this, because you can't actually say, I want overexpressed neuronal genes and build a classifier and then have it work. That's an approach we tried and it just doesn't work. And I'll tell you why. But you can see we have various modules and we group them based on biology. You can see, you probably see a lot of your favorite luminal genes, PPR gamma, et cetera, basal genes, KRT, 14, and so forth. So then we go through this process I talked about, training and testing. And so here we used a clustering approach. And so clustering is just a way that we group patients together, group patient tumors together into categories. It's kind of the simplest way to put it. This goes through a number of iterations, of course, until we're satisfied with what we see. And this is what the clustering looks like. There would normally be groups along the top, but I really want to just highlight the neuroendocrine population. And for those of you who aren't familiar with heat maps, basically on the columns, each of these represents a patient tumor. And on the rows, each of these represents a gene. So you can see we've grouped them into modules here for luminal and basal. So if you track over, you can find patient, say 130, has KRT expression that's very, very low. And the colors indicate intensity of genes. So a 2 is very, very high expression, -2 is very, very low. And this is all scaled to the data set we're looking at. So it's not an absolute value, it's a relative value to their expression within the cohort. And critically here, you can see with the high red expression here in the neuronal markers that this population of patients, this is our target, that's what we're looking for, overexpress neuronal markers, but are very depleted in basal luminal markers. And so what we did here is we went down over this side here. So this is the PTC, the training cohort. We generated a random forest model, and then we tested it on this additional cohort of patients who had radical cystectomy only. And we're basically looking for high expression of these markers, but also poor outcomes. So we kind of literally go through this until we're satisfied with whatever clustering solution we've come up with that finds these patients and groups them like this. And so this results in actually 8 different subtypes, but we don't report on them. So the idea here is that the way the classifier works is it goes down this cascade of these different subtypes, and you can see them listed here. And it asks, is it this or is it not? And once it gets down to the very, very bottom, which is a decision between neuroendocrine-like and unclassified, it can tell you whether it's a neuronal tumor or not. So this basically shows you how that works. So the random forest model is basically a series of trees. So each patient tumor will go through 2,000 iterations of this random forest model, and each tree will give it a vote. So it's basically random how it goes down these trees. And then it takes the highest vote among all the 8 subtypes and says yes, no to neuroendocrine or neuroendocrine-like. So I've kind of gone through all this. This is where I was telling Peter that we do need some expert opinion to help train the model. AI is good, but it'll often bucket patients where they don't belong. And you literally have to go through it and say, no, this patient is neuroendocrine. It should be classified that, and then retrain the model. So then we left the model and we started to validate it. And this is where I stressed that validation was very important. So for this particular classifier, we validated it in over 1,500 patients, including a number with neoadjuvant chemotherapy, a lot with radical cystectomy, 1 TMT course of chemoradiation. We had a series of pathological neuroendocrine tumors, which we used as controls downstream. All of these were actually classified as neuronal-like by our classifier. And then for the patients where we had actually tumor tissue available, we actually did some IHC staining. And I think hopefully this convinces you that these tumors are truly neuroendocrine-like. You can see in group B here, these are our controls, histological small cell neuroendocrine carcinomas. And these 8 tumors here in this group here in A are our patients that we identify as neuroendocrine-like. And you can see your favorite neuroendocrine markers here, so naptophysin. You can see that the patterns across the board are very consistent. So the only one that's kind of different is chromogranin A, which is interesting, and probably something to do with the differential pathways for neuroendocrine tumors. So this kind of, I think, strongly supports the idea that these neuroendocrine-like tumors, even though they look like carcinoma, conventional carcinoma, actually are neuroendocrine.
Logically,
Logically, you're saying these look urothelial,
Correct.
but they look like small blue tumors up on H and E.
Yeah, I can't. Wish I could give you a better, better zoomed in view of
Otherwise, they wouldn't be called small cell.
They're not called small cell.
No.
Right, and that's
No.
the point. They're conventional urothelial by morphology, and they have a neuronal or neuroendocrine gene expression.
Yeah.
And then he's showing here, or we showed here, that they also have neuroendocrine protein expression.
No, I got that. So
Yeah.
you've got a signature that's neuroendocrine. But the morphology, even up top, looks, I mean, yeah, you're right, you can't comment on it, but it just looks kind of blue dark, like a small cell. These are but
That's
pathologically,
pathologically,
these are not.
yeah.
These are called out as a adeno.
You're no
which is
urothelial.
urothelial.
Yeah.
Yeah, but there are, I mean, the four columns.
Or not adeno, but epithelial, I should say.
The four columns in B are actually small cell, right?
Yeah,
So there are
these-
actual small cell.
These
ones
guys
on there.
here. It's easy. Yeah, I mean, it was a pathologist did. It wasn't like I didn't do this part. I wish I'm no pathologist. That's for sure. So these patients tend to do badly. Since I don't want to run out of time here, I'm not going to belabor this, but yeah, they tend to have a bad day. So it was only a cohort they did well in. It was the TMT, or chemoradiation cohort. We really don't have a good explanation for why that might be. Something to look into, but for the most part, these patients are doing quite poorly. So never satisfied with validating just in the cohorts we had, we actually generated another cohort, and this is a chemotherapy cohort, 234 patients. Again, as before, you can see that the neuroendocrine-like patients we identified have very robust expression of neuronal markers, depleted in basal luminal markers, and consistent with before, tend to have poor outcomes. So within 12 months, we had 8 events. So this is a really aggressive tumor type. And again, as before, none of these were small cell histologically. They're all conventional urothelial. So kind of the punchline here is that these patients appear about 6% of the time in our data sets, and you wouldn't see them through routine pathological screening. So we're kind of looking to help the pathologist here, where they're uncertain or even if they're just potentially missing these tumors. They have poor outcomes. They seem to be recalcitrant to standard dose therapy. But unfortunately, and this is where the clinical utility part comes in, there's no standard of care for these patients. Even small cell neuroendocrine tumors presently, and NCCN only recommends etoposide and cisplatin-based chemotherapy, and that's based on lung cancer data. So we don't know what we're going to do with them. And I think that kind of highlights the challenge I was talking about with clinical utility. And so the take-home messages here for the model is really, the clinical problem should ideally be addressable and be able to influence practitioner decisions. Training and testing cohorts need to be representative and of sufficient size and quality. So if you're doing imaging, building a model around imaging, you need extraordinary amounts of data to see patterns. Gene expression, a couple hundred to 800 patients in a cohort is probably ideal to build a good model. And they need to correlate with a goal of interest. So subtyping, recurrence-free survival. You need to lock your model prior to validating. If there's a risk of overfitting. By overfitting, what I mean is if you start to retrain the model to kind of fit the data set you're looking at, you're breaking your models. It's just adjusting it to fit what you're looking for. And that's not correct or how we do things. Validation is key. Without validation, you really don't even know if your model's working. We've definitely built models that we thought were pretty robust, and then on validation collapsed. It's disappointing, but it does happen. And finally, I think the uptake can be quite challenging. We develop these models, but it's not always easy to get them into the clinical setting. And that's been an ongoing challenge for us at the company for sure. Okay, so finally, the alignment of subtyping models. This is kind of a little bit of a noisy space in the field, and we've written a number of commentaries about this, how subtypes align, and it's just an interesting sort of dialogue. A long time ago, about 10 years ago, subtypes were quite reproducible. At the time, we understood there's a basal group and a luminal group, and we were quite satisfied with that. And Lund kind of came up with another classification that was a little bit more complicated, and they had this infiltrated group. And then things started to get worse. Some more classifications started to come up, and you could sort of see as this luminal basal axis starts to fade in the middle, as we get more and more granular models. So there's a lot more noise starting to be introduced. And this is where the controversy of whether subtyping is useful clinically or not starts to arise. And again, it got worse and worse and worse. And so at this point, I think there was at least 9, probably 10 classifications, including the consensus model, which attempted to basically consolidate this and give us something to use as a reference. But again, there's no clinical data suggesting we should use this in practice yet. And so the following, I'm just going to highlight a few of the bigger models, bigger just being more cited. TCGA, the Lund tax, they actually have a number of versions as well, and our Decipher GSC, because I think that one has the most clinical data associated with it. And so some of these issues are just around the clinical decision making. It's like for NAC, for example. So we report, there's no benefit from chemotherapy for neoadjuvant chemo, for luminals, sorry. And Lund goes ahead and says, actually, luminal do benefit from neoadjuvant chemotherapy. So this is sort of highlighting where the issue starts to come from. That's just something from UP. And so I think what we want to do here is let's revisit this problem more objectively. Like what are the issues and how are we going to fix them? And so we see, conflicting results for groups responding to those that do not. So we see luminals doing good with chemo, luminals doing bad with chemo. There's really questionable clinical utility as a consequence of this. Often they have similar names. So you see luminal papillary popping up in a number of different models, but they may not be describing the same thing. And there's a lot of classifiers, and too many of them are starting to cause a lot of confusion. Like people really don't, I think, have any faith that subtyping is useful. And then we have these more and more granular classifiers like Lund, would have 9 classifications, but we're applying them to cohorts that are 100 to 200 patients. So you can imagine each group is then about 10 to 20 patients. I mean, what are we actually learning from this? And so how do we address this? Really, what we can do is we can take these models, we can apply them to the exact same cohort and investigate the biological and clinical similarities and differences, and then see what we're actually looking at. And so going back to NAC meta, we use this cohort to start to look at this problem. So again, for the biology data, we're not using weighted data any longer. So we're actually going to do 601 patients unweighted, but for any of the clinical outcomes data, we'll be using weighted data sets. So what we found then is applying these 3 models and using the Decipher GSC as a reference to this cohort, we saw there's actually a high degree of consistency between luminal papillary and UroA tumors, according to the Lund model, in our cohort. So here you can see that luminal papillary for consensus and luminal papillary for TCGA are very consistent with our luminal tumors. UroA is consistent with our luminal tumors. We're just picking the biggest groups here for this point of illustration here. But there's definitely less agreement between models and the non-luminal subtypes. And the more granular the model is, the less agreement there is. These luminal type tumors seem to have consistent gene expression signatures. So here I just picked a couple of the panels. I think there's about 12 in the paper. But for immune 190, you can see that luminal papillary have depleted immune 190 signature scores. This is just immune infiltration signature. And then for FGFR3, luminal papillary and UroA all have higher FGFR3 signal. What's interesting then is we ask the same clinical questions we asked before, and we say, did luminal patients benefit from chemotherapy? And we see the exact same patterns. So this one's the consensus luminal papillary versus all non-luminal papillary. And you can see that there's a net difference of about 2%. And this is consistent across all these various models, doing exactly the same comparison. Likewise, the net difference in overall survival for the non-luminal papillary patients, again, across the board is about 10%. So we're literally looking at the same patient population, capturing them with different models. Okay, so take home message from that. There's too many classifiers for sure. And there's probably more coming out in the horizon. So this is going to get worse, I think, before it gets better. The consensus classifier, I think, has a lot of utility to providing as a reference point, but it really needs to be kind of tested clinically. And I think this is some of the first evidence that we have that we could use it in the clinic based on what we have seen with our data sets. There generally does tend to be a luminal type agreement, so this is encouraging. I think we are able to capture the same patients using different models. And this really is a population with the highest potential for making clinical decisions in that we might consider treatment de-intensification. And finally, the luminal GSC consensus luminal papillary and TCGA luminal papillary all are capturing the same tumor types of the favored biology. And this is important again because all these subtyping subtyping trials are using TCGA luminal papillary, and they're taking these patients direct to cystectomy, and we're providing evidence using our model that this actually makes sense to do so. And non-luminal tumors are still providing a lot of opportunity, I think, to do some reclassifications. Good. Finally, just if take nothing else home from this, I hope that these following points kind of came through. Really, Decipher bladder luminal tumors have lower rates of upstaging and similar outcomes with or without chemotherapy. So this patient population is probably clinically actionable, i.e. in this case, treatment de-escalation. The Claudin low tumors, I think, another interesting group of patients, given that they're so highly immune infiltrated and have this really impressive response to pembro. I think this could be very promising as an immune biomarker, but we need validation data. Finally, for the gene expression profiling and molecular assay development, the problem really needs to inform clinical decision making. Otherwise, we're just building models for fun, which is interesting, but not necessarily helping patients. You need to lock the model and validate. Like this is a key. Like this is 100% required. I mean, Decipher prostate, even though it's published about 200 times, we're still collecting data to validate this one. Like it's an ongoing process. And finally, with all these different subtyping models floating around, I mean, it's complicated. There's a lot of confusion in the field, a lot of doubt because there's too many models. I think, and there's a lot of work to be done to kind of consolidate and bring these together. That said, you know, there's just definitely a high degree of a similarity in luminal axis for some of the well-known molecular classifiers. And given these are kind of emerging clinical trials, I think this is encouraging for the future. Finally, I'm not thanking nearly enough people on this slide, but you know, it takes an army to do all this work, and it's been a ton of people come through building this out. I think a couple of people to highlight here is Ewan. He was a student who started with me a while ago, and I think we haven't stopped working together since, still building models and stories. Dr. Black, of course, one of the first people I ever met in urology, and I think that's how we got started. A very long time ago, Yair Lotan and Andrea Necki, they provided a lot of the cohorts we use for these studies and data. And with that, we're done.